Welcome everyone to the Community Technical Assistance Center of New York. Today's webinar is Engaging Youth at Risk for Psychosis, but more specifically, youth at clinical high risk for developing psychosis. Before I officially introduce our presenter, I just wanted to do a little bit of housekeeping around the WebEx system, especially if it's your first time logging on. First, I wanted to note that as you can see, the webinar is being recorded. So the recording and the slides will be posted on our website in the next day or two. And the website is www.ctacny.org. And we'll also make sure to chat that out just in case you need the address. Everybody is currently muted and will be muted throughout the duration of the webinar. What we do ask you to do, if you have questions or comments, please use our chat box. The chat box should be on your bottom right. If you don't see a chat section, you can hover over the bottom of the where the slides are, and you'll see a little talking bubble. You can click that bubble, and it should open up your chat box. And that's where you will communicate with us and comments, feedback, questions, respond to any questions that the presenter poses as well. When you submit a comment or a question through the chat, please make sure that before you hit submit, that in the drop-down you click send to all panelists. That way we can all see your question or comment. There will be a feedback survey that pops up at the end of the webinar. We highly encourage you to just take a couple seconds to really complete that, as we do definitely need your feedback about this webinar and others, as well as additional topics that may be of interest, as we do also look at those surveys. If you have any technical difficulties, as you can see from the chat in the chat box, please make sure to contact the host through the chat box. That just in the drop-down, make sure it says host if you're having any computer audio difficulties throughout the webinar. We are currently going to hold all your kind of Q&A questions for the end. We'll make sure to save at least 10 minutes or so at the end for Q&A, but you feel free to submit those throughout, because we'll keep track of those as well. So without further ado, I would like to introduce our presenter, Dr. Shelley Ben-David. Dr. Ben-David is an assistant professor in the School of Social Work at the University of British Columbia. She's a social worker by training and has previously worked at the Center of Prevention and Evaluation, or the COPE Clinic, at the New York State Psychiatric Institute. Her program of research focuses on how adolescents and young adults with serious mental health challenges and their families make decisions about seeking mental health services. Thank you so much for being with us today, and welcome, Dr. Ben-David.
Oh, hi. Thank you so much. I'm honored to be here today, and I think I'll begin. So again, my name is Shelley Ben-David, and today I'm going to be talking to you all about engaging youth at clinical high risk for developing psychosis. And just briefly, a little bit about myself. So I lived in New York City for about 11 years, and I did my graduate training there. So I went to Columbia University to get my master's in social work. And then after that, like Lydia mentioned, I worked at the Center of Prevention and Evaluation, the COPE Clinic at the New York State Psychiatric Institute. And there, the COPE Clinic works with young people at clinical high risk for developing psychosis. And so that's where I got a lot of exposure to working with these young people. And that actually led me to do my PhD in social work at NYU, where I did go back to the COPE Clinic to do my dissertation. So I did a qualitative study with the young people, where I interviewed them and really explored what were barriers of facilitators to seeking mental health services at that clinic. And so today I'm going to present to you some of the findings and how and what kind of strategies can we implement in terms of engaging young people. Currently, I'm at the University of British Columbia, and I'm continuing my research in Canada. So let's begin. So just a brief overview. The first thing I want to do is just briefly talk about how do we identify these youth at clinical high risk for developing psychosis. This is the question I get asked the most. And so hopefully I can just shed a little bit of insight into who these young people are. And we'll go over a couple of case examples where we can have a little bit of discussion. And then I want to dive into my findings, looking at factors that facilitate and impede engagement with these services among these young people, and weave in strategies to engage with this population with services within that portion. Before I begin, I just want to always want to acknowledge the young people that have shared their stories. I want to acknowledge the funders that funded my dissertation, the New York Community Trust, and NYU Dissertation Research Fund, and of course the co-authors that helped me with this, that we worked together on this study. And so let's talk briefly about how do we identify these young people. And so first I want to just do a couple slides about psychosis and schizophrenia spectrum disorders. So when we think about psychosis, we think about a period of loss of contact with reality, with disruptions in the way one thinks, feels, perceives, and behaves. And within the DSM-5, there are key features of schizophrenia spectrum disorders, and so that includes positive symptoms such as delusions, hallucinations, disorganized thinking, and disorganized behavior. And we also have negative symptoms, and this might include a little display of emotions, lack of motivation, decreased ability to experience pleasure, a lack of interest in other people. And when we think about, one thing I often get asked is, what is the difference between positive and negative symptoms? So when we think about positive symptoms, we think about experiences that are added on to everyday experiences that the general population typically does not experience. So for example, hallucinations, so hearing voices is one example. And when we think about negative symptoms, we think more of a loss of everyday experiences. So for example, experiencing loss in ability to experience pleasure or lack of motivation, and we know that this is most common in schizophrenia. And so let's kind of dive into this clinical high-risk phase. Like, who are these young people? We know that this phase typically develops during late adolescence and your early young adulthood. We know that for many people who experience the first episode of psychosis, they also experience this kind of stage, and prior to developing a first episode of psychosis. And I think the key thing that is important to remember is that young people will be experiencing something called attenuated positive symptoms. So they'll be experiencing subthreshold delusions or subthreshold hallucinations. So what we mean by this is that a young person might think that they're hear their voice being called in the wind, or they might see something out of the corner of their eye, but they're still kind of struggling. They're still thinking like, well, what's going on here? Is this really true? And so there's really the critical thing is this insight piece. And so, for example, a young person who might be experiencing a first episode of psychosis, they're like, I'm hearing voices. I really feel like this is happening to me. Versus this clinical high-risk phase, the young people are still struggling. They're like, what is going on here? What is this really real? And so I think this is the most critical point to take home today. Young people also might experience negative symptoms, and there also has to be a functional decline in their school or work or whatever it is that they're doing in their lives. And so when I was working at the Cove Clinic, I worked on many different research studies, imaging, stigma studies, qualitative studies, and I wanted to just bring in a couple quotes from the qualitative studies to kind of paint a picture of who these young people are. And so oftentimes these young people might talk about feeling broken. So one young person says, maybe in my head something did not develop properly, or there's something missing. So here you can really kind of hear that they're struggling with, like, what is going on with me? Why am I feeling this way? This doesn't feel like right. Young people also might experiences like feeling like they're going crazy, like the anxiety about being crazy was worse than forgetting a meal. They also might begin to experience problems with communicating. One young person said to us, I want to communicate to other people, but sometimes I feel like I'm just mumbling over some kind of mountain. I'm trying to make myself understood, but they just can't hear me, no matter how hard they try. And also, young people also might have a fear of like developing a mental illness because of a family history. For example, one young person says, there's such a history in my family of thought disorders, and I have pretty much known my whole life that I have a higher chance of going nuts than any other people. So just wanted to provide these quotes just to kind of paint that picture of like the struggle that's going on within these young people. One thing I also just kind of wanted to bring up is that currently the attenuated positive syndrome is in the DSM-5 for conditions for further study. And I wanted to bring it up because I think it's important to know that this is currently in this section, and really I wanted to also bring on the point that there is debate within the community of whether this should be in the DSM-5, and some of the points really are because of just the stigma, just the experience of stigma that young people may feel if they are given this clinical high-risk phase diagnosis, and also just the idea that young people might be overprescribed antipsychotic medication. And so again, this is still kind of, we'll see what happens. Will this remain in the DSM? That's something that we'll find out. But whether or not this does remain, if this does remain in the DSM-5, I just want to talk about how important it is to have the importance of early intervention for this phase. And so we'll talk further about this when we go into slides in the next coming slides. Another thing I want to say is that if you're really interested in getting more of an overview of the stage and get training and utilizing more, assessments, if you want to get trained. So the structured interview for prodromal syndromes and the scale of prodromal symptoms, the SIPSOPS, is something that I was trained in when I was working at the Cope Clinic. And this is the scale that we use to identify young people at clinical high risk for developing psychosis. So if this is something that's interesting for you, or if this is something that's interesting within, if your clinic is interested in getting further training, then I really encourage you to look up this information. This is through the Prime Clinic at Yale University, and I think that the trainers can come to your site for a 2-day training. So please take a look at this contact information. And so what I wanted to do just briefly is just go over a couple of case examples to kind of get home some of the points that I'm trying to bring home in terms of this clinical high-risk phase. Now, remember that we can't really make any diagnosis based on just the limited information of a couple bullet points, but I just wanted to kind of practice some of these ideas and concepts. So feel free to chat within the chat box to let me know what your thoughts are. And so I'm going to read the first vignette. And so we have a 17-year-old Charlie. He first accessed services for problems with concentration at school and chronic headaches. He failed several classes and recently stopped attending school. He has problems with sleep, playing video games all night and falling asleep by 5 a.m. and sleeping late into the day. He avoids his classmates and worries that they have been talking about him behind his back because he hasn't been pulling his share of work. He admitted to his counselors that he fears that some of his classmates might be out to harm him. When questioned further by the counselor, he stated that he does not believe that his friends are going to actually harm him, but feels the need to remain on guard just in case. So I just wanted to see what everybody was thinking. What are your thoughts when you're reading this vignette? Do we think that this young person is maybe at clinical high risk, or do we think this young person is experiencing a first episode of psychosis? What should we be focusing on in this slide? And again, remember, it is limited information, and so just kind of wanted to generate some sort of discussion.
So just as a reminder, make sure to use that chat box on the bottom right. And again, if you don't see the chat box, when you hover over the slide, you'll see these little circles with a bubble that pops up. You click that, that opens the chat box. And sometimes it takes a couple seconds for us to kind of get that chat. So please go ahead and submit those in now. Make sure you submit to all panelists in the dropdown.
And so I just saw some comments saying sounds high risk and need for further assessment ASAP. Another person saying, I think he's at risk. I'm noticing he's suspicious and there's a decline in his academic performance. Exactly. Why does he think classmates are talking about him? That would be a great question to ask. I think he may have anxiety and depression. Yeah, exactly. And how do we know that? Why would we think he's clinical high risk phase and not experiencing a first episode of psychosis if we were going to go that way? And this kind of goes back to that slide I said earlier about the attenuated positive symptoms, and that and the idea for that is a young person do they have some insight intact? And so when we read the line, so he admitted to his counselor that he fears that some of his classmates might be out to harm him. And then I see someone saying he doesn't believe his friends are actually going to harm him. Exactly. So again, we of course we need to do more assessment. There's not enough information here. But when questioned further by the counselor, he stated that he does not believe that his friends are going to actually harm him, but feels the need to remain on guard. And so you can tell that he's struggling. He's like, well, I think they're out to harm me, but maybe I don't really believe that. And so I think that that's kind of important to kind of further assess when a young person is talking about these experiences, to really see, well, how much do you believe that this is actually happening? What is the conviction into these experiences? Okay, so let's try another one. So for Vignette 2, Jess is a 20-year-old bartender and student. She has a family history of schizophrenia and has problems taking care of herself, and recently fired from job because of the numbers of days missing work. She spends most of her time watching Netflix and daydreaming, and has been fighting more often with her significant other. She believes that psychic powers run in family, and she's getting messages from the TV show Sabrina that she can read minds. When probed by a therapist, she stated that these experiences feel real, and she has begun to sell some of her belongings to pay for online spells. She feels worried that she may have inherited her mother's mental illness, and she's been feeling down in the dumps. And so what are our thoughts here? What do we think is going on? Do we think that she's still in the clinical high-risk phase? Do we think do we need to do further assessments? Do we think that maybe she's experiencing a first episode? And remember, again, there's a limited information, but I just wanted to try and get some points across here. And someone said first episode, so that's what I'm hearing here. And so why do we believe that this is happening? Why would we think this is first episode and not necessarily a clinical high-risk phase? And yes, somebody just pointed out that there's a very high risk due to family history. Exactly. Decreased work productivity and positive symptoms. Active symptoms, I would admit to ER, possibly depression with psychotic features. Exactly. Again, we have to do a further assessment. But the one thing I want to bring home here is that when she believes that she has psychic powers and that she's getting messages from the TV show, and when she was probed further, it seemed like the insight was less here, that she says that these experiences feel real to her. And so in addition, she's begun to sell some of her belongings, so she's acting on these experiences. And so again, I think that in this case, as opposed to the Vignette 1, where when probed further, he was like, oh, I'm not sure if this is really real. I'm not sure if the people are going to harm me. In this case, she does believe that these experiences are actually real. And so again, the main point is that, and what people are saying here, which is great, is that further assessment is important. We really need to understand what is going on here. And I think, but hopefully everybody here kind of starts to get what I mean by the clinical high-risk phase is that insight, is that do they really believe that this is happening, or are they still struggling and wondering what is going on? This doesn't feel like it should be happening. This doesn't feel like this should be real. And so when a person is experiencing more of a first episode, they're like, this is really happening to me. And so when you're working with young people, you will really want to start to distinguish what exactly are these experiences, how real do they feel to the person? Are they still struggling? Do they believe that they're real? Or are they, again, still kind of conflicted? Thank you so much, everybody, for your thoughts. So let's carry on and talk to you about my work with the young people, and we'll look at what were barriers or facilitators to seeking mental health services with these particular young people. And so why is it important that we work with these young people? We know that there's increased rates of suicide among these young people. We know that there's a higher chance of school dropout and comorbid mental health problems. We know that about 20 to 40% of young people in this stage do develop a psychotic disorder. So it's not all of them, but some of them do. We do know that young people who experience the first episode of psychosis, we know that many of them have this kind of prodromal phase. And so we know that it's important that we kind of identify and work with these young people prior to developing a first episode of psychosis. We also know that the delays in treatment for psychosis lead to worse outcomes. So the earlier we can intervene and the earlier we can work with these young people, the better. And again, just kind of, early intervention is critical with these young people. And so the problem is we want to get young people to care, but from my work at the clinic, when I was working there, I noticed that a lot of the young people maybe came to one or two sessions, but it was really hard for them to stay engaged with services. And so that's kind of what led me to want to do my dissertation to understand mental health service use among these young people, because we know that there are high rates of underutilization of mental health services among these young people. We also know that these young people have the capability to recognize that they have a problem. And as you can see, they're struggling. They're kind of going, they're like, what is going on with me? Why does I feel broken, or I feel like something is going on within me and internally? We also know that they have the ability to make decisions about seeking mental health services. The problem is, in the literature, there really was not a lot of research looking at mental health service use among these young people, and there wasn't a lot of research looking at the first-person perspective, which is why I wanted to go and do research to understand this experience. And so these were the two aims of my study. There's citations if you're interested to go and read them. The first aim was to really understand the first-person perspective of these young people, what keeps them engaged or not engaged with services. And the second aim was to understand the decision-making process that young people make when seeking services at the clinic by applying a decision-making framework. And so what I'm going to do today is present on both of these findings, these aims together in one presentation. Just briefly, I interviewed 30 young people. The mean age was 23. The age range was between 18 to 30. 60% were male, and in terms of race and ethnicity, it was pretty heterogeneous. And about half of them were receiving clinical services, and half of them were only going to the clinic for research purposes. And so this was the model that emerged from the findings. And so on the left-hand side, you can see that there were social and community and these are social community and online networks. And so young people were receiving messages from people, family and friends in their lives, from their community and from their online networks about seeking mental health services. And so you may think that, depending on the type of message, it may impact whether or not a young person actually seeks mental health services. Young people were also, this group also experienced a lot of stigma. And so the more stigma a young person experiences, the harder it is for them to seek mental health services. Young people also experience a lot of different types of emotions when they thought about seeking mental health services, and so positive or negative emotions or mixed emotions. And again, this may impact how they stay engaged with services. Also, how much awareness they have into their own mental illness may also impact their service use, as well as facilitators and barriers that impact their service use. So what I'm going to do is I'm going to go through each construct and talk to you a little bit about what we found, and within that, I'm going to provide you with some engagement strategies that hopefully you can start thinking about implementing at your clinic. Okay. And so let's begin. So the first things I want to talk about are the networks. And so young people were experiencing certain they were experiencing negative messages from specific racial ethnic communities about seeking mental health services. And so African American communities, Eastern European communities, and Dominican communities. And so, for example, one young person said, I would say that my experience, there's a lot of stigma about getting mental health services in the Black community. There's been several instances where people tell me you don't need to seek help, you just need a good friend or family or person to talk to. Young people were also experiencing positive, negative, and mixed messages from their social networks, so from family and friends, about seeking mental health services. For example, a young person received messages from their parents that the resources at the clinic is helping you. So this was more of a positive message. And so you might think that positive messages may encourage young people to seek mental health services. Young people also receive, we found positive messages from their online networks. For example, one young person said that I was reading a forum for schizophrenic people and I made a post about saying how I feel, and they told me there might be a place in the city where I could go and talk to people for free. Again, more research needs to be done in this area, but this is really interesting to think about the messages that young people get online. And so when we're thinking about strategies, engagement strategies with these findings, the one thing that I think is important is that we're including family members as part of the treatment, and we're also kind of engaging with family members to understand what their thoughts were about seeking mental health services, and so that they have more negative or more positive message about seeking mental health services, and also providing some psychoeducation to the communities and families about the clinical high-risk state, because we really want to reduce the stigma that these communities or families or friends may experience, and we want to increase their buy-in to services, because if they have more buy-in to the services, then they might be passing on more positive messages to the young people who might stay more engaged with services. But we also want to work in collaboration with community leaders and think about, well, is it the best place to provide services at my clinic, or can we start to provide services at churches or at community centers? And so we really want to think about how to work with communities to ensure that that everybody has a buy-in and that we can really provide the best services to that community. We also want to think about the importance of online mental health apps and communities, and really start to think about how we engage with these communities and how we understand what's going on, because we know that young people are accessing online apps and communities more than any other generation, and so we really want to explore what are the messages that young people are receiving within these communities, and how can our clinic work with these online communities to increase engagement with services. And so one of the most highly endorsed themes was stigma. And so I'm going to go over a couple of the stigma themes. For example, young people experience hierarchical stigma, and what I mean by this is that psychotic symptoms are viewed young people said that psychotic symptoms are viewed as the most stigmatized symptom compared to other mental illnesses or symptoms such as depression or anxiety. So, for example, one young person said psychotic symptoms are especially something that you're supposed to not talk about or keep hidden. And people are afraid of people who have experienced psychotic symptoms. That's like definitely the one kind of symptom that people really don't understand if they've never been mentally ill. And so we can think that if a young person is experiencing this complex type of stigma, it might be harder for them to stay engaged with services. Young people also experienced public and internalized stigma. Public stigma was highly endorsed. Almost all the young people talked about this. When we think about public stigma, we think about more negative attitudes and beliefs by the general public towards people with mental health challenges or the family members. And so, for example, one young person says, it's always talked about, like in the media, people with schizophrenia are scary, or are the people who shoot other people in schools. And that kind of leads into internalized stigma, which is more the internalization of these negative attitudes. And this could lead to young people being more secretive and not wanting to share their experiences or not wanting to stay as engaged with care. For example, one young person says, it's kind of terrifying, but I'm glad it was sort of spotted. But there's that feeling of being distraught, like, am I that crazy? This also leads into this idea of disclosure and how open are young people to talking to clinicians or to clinics or to family members about their experiences. What we found in our findings, in our samples, that most young people only partially disclosed that they were seeking services for these symptoms. One young person says, I'm not going to tell people I'm seeing a psychiatrist and therapist. That's silly. I can't do that because they will begin to question me. And so when we think about this, we really need to think about when we're meeting with young people that are coming to our clinics, are they actually disclosing these experiences? They might not. And so when we think about engagement strategies in terms of stigma, one thing that I think is really helpful is that when you're initially meeting with young people, you want to provide some positive image of the type of young people that seek mental health services. And so, for example, these were some of the types of images, positive images that young people told us. So a young people that seeks help is interested in getting help. They're brave, they're in distress, and they want alternative ways to cope. And so these are the type of images you can start to provide early on when you're meeting with young people to keep them engaged with services. The other thing that was just so important that we found is this universality of experiences. And so the young people in our sample, they said that when I was at the COPE clinic, it was so helpful when our clinicians said that you are not alone in experiencing these experiences. That there are many young people that share these same experiences, and I've heard this before. And there's nothing more. These young people felt so much relief when they heard this. Another thing is that we need to start to try and increase our environment so it's more stigma-free. And one thing that I think that is really important is, as clinicians, that we're checking our own biases and our own views about schizophrenia, our own views about psychosis, and I think that's really important as well. Another thing that's really important that emerged from our findings is this idea of emotion. So young people talked about feeling a whole range of emotions when they thought about seeking mental health services at our clinic. For example, young people talked about experiencing positive emotions. So when I finally got here, I felt happy, hopeful, relief. They talked about feeling negative emotions that included maybe shame, fear, and confusion. And they also talked about experiencing mixed emotions. So, for example, one young person says, I was really excited at first, and I still love it here, but I was so confused. And so when you're thinking about engagement strategies, I think that it's really important that early on when you're meeting with a young person, that you're really paying close attention to their emotional reactions to services and to the care that you're providing them. And that what you're doing is you're normalizing the emotions, and you're like, it's normal to feel anxious or nervous when you're coming to care for the first time. But it's really important to know that it might make you feel it might provide you with some relief as well, or it might make you feel happy as well. And so I think that it's important that we are paying a close attention to these emotional reactions because we want to keep young people engaged with services. And so if they experience more negative emotions when they come to care, they might not be as motivated to keep on coming. And for example, with the young people that I work here in Canada, one of the reasons why we sometimes can't bring them in is because they'll text us and say, I feel too anxious today to come in. And so really, I think that what's important is, in addition to normalizing these emotions, you also want to provide young people with skills to regulate their emotions. And for example, mindfulness could be one tool that you're using when you're working with young people. Another thing, so now we're going to talk about facilitators to services, and this is what emerged in our data. And one of the most highly endorsed facilitator was the young people saying that expertise of services was so critical. So the people at the COPE clinic had expertise. They knew what the clinical high risk phase was. They knew about psychosis in young people, and this was so important to them. And that's why I feel so honored to be here today to kind of let everybody know, all the clinicians out there know that what you're doing right now, getting more education on this clinical high-risk phase, and hopefully you'll continue to do this, or you already have been doing this, but this is really important to young people. And so one young person says, knowing that the people here know what they are doing and have experience is what keeps me going here. And so again, just to emphasize how important this facilitator was. Another thing that was really important to the young people was the efficacy of services. So it was really important to the young people that the services that they got helped alleviate symptoms and improve their functioning. So for example, one young person, some young people say, we use CBT to tackle most of my fears and anxieties. Services help me get out of my funk. Services help me have better interpersonal relationships. And so really this is so important that the young people know that the services are actually going to help them. And if they feel that, then they'll stay more engaged with services. Another thing that's really important is the clinical factors. These were facilitators that emerged. And so really this is something that what they said that was important to them was tailoring therapy towards their needs. This therapeutic alliance was so important to him. The fact that they feel or they believe that treatment can help was so important to them. Some of the young people said, he is the first therapist that I've had that I actually felt can help me. And so again, when you're thinking about working with young people, you really want to build this therapeutic alliance with them, and to ensure that their needs and what they want to work on is actually being met, and that they actually know, or you as a therapist acknowledge that these are the things we're going to work on, and you're kind of working together to decide on what are the goals or what are the needs within those sessions. Another thing that was so important is the social connection. And I felt this when we were at our clinic, because we really developed relationships with all of the youth. And it wasn't just with the therapists, but it was with the staff at the clinic. And so from the reception to the different researchers to the clinicians, they came in and they felt like this was a place to get social support. One young person said, you have these deep connections with people who want to help you. Another thing that was really important, and I know that this isn't always the case with all different clinics, but within our clinic, we were able to provide them with free therapy. And also that they had services all in one place. And so that was really important for these young people. And so when we're thinking about engagement strategies, as practitioners, I think one thing that you can focus on early on and to keep young people engaged with your services is to work with their attitudes towards services. So you really want to let them know that the services that you're going to work with them today, the services you're going to provide them will help improve your symptoms, will help improve your functioning, and this is how, and this is what we're going to do. We also want to ensure that we can let them know that, well, we have expertise or we have knowledge in this space. Because again, that expertise piece is just so critical for these young people to know that there are people that can help them. Because they talked to me that prior to coming to this particular clinic, when they were at other clinics that didn't specialize in this phase, that people didn't really understand how to help them or really didn't understand this phase. And so really ensuring that you have some sort of education is so critical, and that you have some knowledge and you have some confidence in this area. And the other thing that I think is so important is this relationship building, and this idea that social support is embedded within the clinic from the staff, from the receptionist to the therapist is so critical. We want to continue to do this and make them feel like when they come in, it's less like a clinic and more like a family, or more like a coffee shop or a place for young people to come to receive care. And we also really want to ensure that we're building that therapeutic alliance with the young people. And finally, as clinicians, you want to gain confidence in working with this population. So now I just want to talk a little bit about some barriers to access, or barriers to being engaged with services. And one of them that emerged was the lack of access. And I think that oftentimes young people do experience these type of barriers. For example, transportation, the temporary nature of our clinic, so the fact that it was only for 2 years and then they couldn't get care anymore. The lack of access to the therapist, the waiting list, so this was some barriers to getting care. And so oftentimes it's harder to change these types of barriers, but at least acknowledging them and finding kind of youth-friendly ways to problem solve, it could be really helpful. And we'll talk a little bit more about that in a second. Another thing that is really important is the physical environment that they're in. So the young people that came to our clinic, it was at a big hospital, the New York State Psychiatric Institute. I'm not sure if any of you have ever been there, but when you get there, it can be really confusing to really find where the clinic is. And so they struggled with getting to the clinic and how it was confusing. They also talked about how it felt like a hospital, and the idea of like the stigma that's associated with psychiatric hospitals were barriers to these young people. Another type of barrier that emerged were problems with scheduling. So in addition, not feeling understood or respected by their clinicians was also a barrier. Issues not aligning with the clinician's agenda and clinicians' mannerisms. So really these are some barriers, and I really think the main point is that the young people want to feel that they're understood and that their issues are aligned with the agenda, with the services. And finally, another barrier that emerged was seeking services at the clinic leads to the experience of negative emotion. So a lot of young people talked about this, that when I go to therapy, it makes me feel bummed out or worried, or I'm afraid that I'm going to develop schizophrenia. For example, one young person says, the reason I didn't want to see a therapist is because I would be worried that it would send me into a negative spiral. So again, working with young people to acknowledge that these are emotions that might experience and to provide them with tools to regulate these emotions are really critical. And so when we think about engagement strategies to reduce some of these barriers, we really want to provide, again, psychoeducation to youth about the expectations about services at the clinic and just the expectations about services with therapy and like what to expect and how to manage these negative emotions. We also know that a lot of these young people have experienced a lot of trauma in their lives, so we want to encourage a trauma-informed approach. We want environments that are youth-friendly, and oftentimes you could work with some youth to ask them, well, what are your thoughts? How can we make our clinic more youth-friendly for you? Sometimes it's really hard, especially if it's in a large hospital or center, to make it more youth-friendly. But one thing I would encourage is to provide user-friendly or youth-friendly directions to how to get to the place. And also, how can you make your space more inviting and more youth-friendly within that, if you're within a large hospital? You also want to consider having peer navigators at the clinic. This is something that young people told me it was very important, that they wish there were more young people that maybe had some lived experience that could provide them with some social support even within the clinic. So these are things that we want to start thinking about if possible. And so just finally, a couple more minutes. So we know that specialty clinics for young people in this stage are limited in the U.S. And we know that even for those young people that get to these clinics, that not all young people will get access to these clinics, especially youth that are low income, minority, and live in low resource neighborhoods. And so that's why it's so important that I get to talk to all of you today, because you really want to start to be able to identify this clinical high risk phase and increase assessments within the community mental health clinics. And also you want to start to think about how do you reduce stigma at these clinics within the families and communities. You also want to know where to refer this youth to get more specialized care. So if you can identify these young people, then you can start to refer them to more specialized care. And these are some resources if you're interested to get more information about the clinical high risk phase and, for example, where to refer them to. So there's the COPE Clinic at Columbia University, and there's also On Track New York. And this is a slide to get more information if you're interested in more of training and to understand, especially if you have a young person who you might think is in the early phase of psychosis. You can always refer them to On Track New York, and they could do a further assessment with them. And so thank you so much today. I really appreciate it. And I think we have some time now for some Q&A. We have about 15 minutes.
Yes, thank you so much. We have actually a good amount of time for some Q&A. So please go ahead and start submitting your questions through the chat box. And we've also been keeping track of some that have been coming in. So again, use that chat box on the bottom right and make sure to submit to all panelists so we can see your questions. I do want to thank you for giving us a great overview of what clinical high risk looks like for this population and what it means. I think you gave a number of really great examples, as well as the challenges in engaging this population and things that folks can do in whatever type of setting they're in, whether they're in a setting that does more work with this population or in a more general setting. I think there's a number of strategies that you gave that folks can think about. It definitely sounds like there is a lot of interest in learning a bit more around this stage, so I think we'll take that into account in future CTAC offerings as well. And I did want to point out that we also have a youth peer advocate system here in New York that is called Youth Power, really comes out of Youth Power and the group of families together in New York State, where, and that ideally is going to grow with time as well. So there is an opportunity to leverage youth peer services as well to work with this population. And I just wanted to highlight, again, the ontrackny.org website. You can go to their sites across the state, and you can reach out to them to see if there's information that they can give you, or maybe you can refer somebody for assessment or treatment, especially if you think they may be eligible. And their website is actually a wealth of information. I know that they have some openings in a few of their programs, for example, the one in Westchester, because they had reached out to us. So we know that there is definitely availability there as well. And there are other directories out there. For example, the second bullet that also lists other types of programs as well, that both across the country, but includes New York as well. So in case that's of interest to you, we wanted to make sure that you had a number of resources there. Okay, so please make sure to use that chat box to submit your questions. I think we already have a few that we can start off with. And so one came up when you were talking about universality of experience. And so peer support, for example, in like groups, for example, has that been found to be helpful in engaging youth at high risk and or experiencing a first episode? What are some, I think you started talking a little bit about peer support. Do you have any additional thoughts there?
Well, I do think that peer support is really critical. For example, a lot of the young people said to me that I wish there were groups or wish there were people that I could talk to who are also experiencing the same experiences as me. So I really think that we have to start thinking to having more peer support within our clinics. For example, where I work with Foundry in Canada. It's a one-stop shop mental health services, integrated care, and we do have like peer youth navigators within our clinic who are there and able to talk to young people with lived experience. You know, these young people may have lived experience as well, and so they can kind of help orient them to therapy even. See, they're kind of like hanging out at the clinic, in the walk-in clinic, and again, where we work at, it's kind of like a very youth-friendly center, kind of designed by the young people themselves, and I think that this kind of model is really important. I think that it really makes young people feel more like this is a place for them rather than like a clinic or a hospital. And again, if there are young people kind of circulating, walking around, kind of providing that kind of support and like onboarding to therapy, I think that that's really critical. I had a young person say to me, I can't believe that this place, I thought that therapy was so different in my mind. I thought that it was like I'm lying on a couch and there's a psychiatrist and you know, just this kind of, then he said, like, this is why I never wanted to come to care. But when I got here, you know, there's people around. It feels like a family. It feels like a coffee shop even. And I wish I had come earlier. And so really having more of this kind of youth-friendly, having peers part of the clinic or part of the treatment, having groups, I think is really critical.
Okay. And we have there's a nuance to a question around is if you see somebody as high risk, is it preventable as far as you know? And similar to that, it's also, you know, can you see symptoms even younger? So there's like two sides, I think, to a similar question. Can you respond to that in any way?
Yeah, those are great questions. I wouldn't say that we can prevent the high risk, but one thing that I think that is, but we can provide services to make that if they do experience a first episode, that it feels that they're already in care, and so we can already give them with tools to how to deal with these experiences. I think also it's important to note that not all the young people that are in this phase do develop a first episode of psychosis. And so that's also important to remember. And, you know, while, you know, this is still like a new field, only the past 20 years. And so, you know, we are working on providing, you know, tailored interventions for this phase. But I do think that, you know, again, the earlier we intervene, the better we can help with outcomes. In terms of young child at risk, I haven't, you know, I think there are some cases where a child can be at risk. I think that typically it develops during, you know, adolescence and early in adulthood. So that's more the type of young people that I have seen. But, you know, there could be children that are at risk, but they may have, it might look a little different than than an adolescent. They might be a little sicker if they were experiencing these symptoms earlier on, like when they're a child.
Great. And then we also had a question around any recommendations for techniques or frameworks when working with youth experiencing paranoia and hallucinations, especially related to just supporting them through the experience. Do you have any recommendations there?
So for young people who are already experiencing a first episode of psychosis, is that what we're saying here, or young people at risk?
It sounds like they're experiencing paranoia and hallucinations, so they may have already, yeah.
Yeah, so, I think that the key things that you have to think about are, getting them into care and providing them with different, we have CBT for psychosis now, so there's different types of, interventions that we can use that are catered to these young people, making sure if we can that the families are also engaged with care, and really supporting them through these experiences, normalizing these experiences, making sure that the environment is stigma-free, really getting them in care and working closely with the therapist and hopefully with the psychiatrist to come up with the best plan. I think it just really depends on the young person that you're working with. And really tailoring the treatment. So it really is kind of like a shared decision-making, approach where both young person and clinician can come up with the best treatment for that particular young person. But there are a lot of resources out there. Yeah.
Yeah, and I think we're kind of straddling questions around treatment recommendations and engagement, and I know a lot of the presentation is really about engagement. But I do have a question around engaging family members, and have you had successes there or recommendations around engaging the family members?
I think that engaging family members is so critical, and I think someone said, is that something when the family member has a mental illness as well? I think that that it's so important that we engage family members and help them. For example, if they're experiencing a mental illness, help them get connected to care as well. I think that, again, understanding what their messages are in terms of treatment and mental illness is really important, so we can provide psychoeducation about the clinical high-risk phase and about therapy and about treatment, and to kind of work with them if they're experiencing more stigma within that family or within that community, to let them know that this is how important getting treatment is. I think it's really important that we do engage family members, and because I think that if family members, again, have the buy-in, that then they will help encourage their young people to get care, because we know that family members are so influential in getting young people in early stages of psychosis to care. And so I think we really need to engage with them to understand what their thoughts are about the clinical high-risk phase or about early stages of psychosis, and to help them and to give them services so they can cope.
Thank you. And then we have a set of questions around sort of dual diagnosis or substance use and this high risk or first episode, and they seem to sort of go around which do you treat one first versus the other. Do you have, I'm not sure if this is kind of your area, but do you have any suggestions around working with a youth who's also using substances?
Well, I mean, it's a really important question, because we know, we know that certain substances such as cannabis are a risk factor for this phase. And we know that a lot of young people, for many of them, they do use cannabis or they are using substances. And I think that when you're thinking about dual diagnosis, you really want to treat both of them and not just one. I think it's really important that you are providing services for both and treatment for both. And I think that, again, it's kind of working with where the young person is at, and kind of saying, well, what is the most important thing that you want to work on right now? And I think that, again, together you can kind of come up with a treatment that, again, feels like the young person is getting their needs met. So I think that's also really critical, but I do think that we need to treat both, and because it is an important issue. We do know that, cannabis use, we know that cannabis is a risk factor for this stage. And if a young person is using cannabis, it could induce this phase, and which is really problematic. And so we need to provide more education to the communities and to young people about these risk factors.
Great, thank you. And then I think there was somebody asking about CBT programs in the area. And I would think reaching out to like the On Track New York, I believe they utilize some methods of CBT as well for this population. Absolutely. Some of these programs that we had said are specifically attend to this population would be a good fit to reach out to. So I would check out those resources. Remember, the recording and the slides will be posted on our ctacny.org website, so you'll also have that available to you, and you can kind of look at some of those resources as well.
And also, if anybody's interested, they can, I have my email address over here, and there are definitely a lot of resources for CBT for psychosis, so feel free to reach out to me, and I can send you some articles and citations for books if you're interested. And also, if you have any questions about anything I talked about today, feel free to reach out to me. I would love to hear from you and provide you with some information.
I think there was maybe one question that we didn't quite get to around what if a client may be at high risk, but they're part of a cultural group who normalizes the symptoms, so they're not necessarily experienced as negative. Any thoughts around that from some of the work you've done?
Well, I think the first question to ask is the client feeling distressed? You know what I mean? I think that really we want to provide, usually in this clinical high-risk phase, you want to provide services for young people who are in distress and are help-seeking. And so and it is complicated, though, because if the culture is, if that's more of a thing within the culture where it's not a negative thing, then, you really want to, again, work closely with the family and closely with the young people to really understand, well, is this young people in distress? Are they not doing as well in school or in their functioning? Or if they're doing okay, if they're managing, then, maybe we don't need to work with them. Maybe they're doing okay. I think it really depends on, like, how distressed they are and and are they not able to function, or or get out of bed, or, are their symptoms really overtaking their life so they can't manage? And I think that that's really important to assess.
Great. Thank you so much. I think we're about at the end of our time. And again, feel free to reach out to Dr. Ben David if you have any specific questions around the content. If you have questions for us at CTAC around this training or other trainings, just go to ctac.info@nyu.edu. You can send us a message that way. You can always check out this training and other trainings at ctacny.org. And again, the recording and the slides will be posted probably in a day or two on our website. So feel free to check that out. At the end of our webinar, a feedback survey will pop up, so please just take a second to complete that. We also had some, I think, reference and slides. There's a number of references here. Again, you'll have the slide deck, so you can kind of take a look at them. There's a lot of great resources that Dr. Ben David has shared with us. So I just wanted to take a minute to thank everyone for participating in today's webinar and taking the time out of your busy day on this important topic, and Dr. Ben David for giving us a wonderful presentation that really kind of, I think, helped a lot of us think through how best to serve this population. So thank you again.
Thank you so much, everybody.
All right. Thank you, everyone, and have a great rest of the day. Take care.